Welcome to the Hard Things About Healthcare, where we get into the business and operations of healthcare that clinicians face every day, the challenges they present to delivering care and running clinics, and how they overcome them. The Hard Things About Healthcare is brought to you by Honey Health, the connected care platform for modern healthcare teams. I'm Matt Faustman, type 1 diabetic, and co-founder and CEO of Honey Health.
I'm Ginger Vieira. I've type 1 diabetes for 25 years. I'm a diabetes author, speaker, and content specialist. Good morning, Dr. Lee. Thank you so much for joining us. We are really eager to pick your brain and learn from you. I want to start with just one very clear question. How did you end up in endocrinology? What led you here?
Great. Thanks, Ginger. Thanks for having me here. So endocrinology, so what was really fascinating to me early on, if people who aren't aware of the medical training, people specialize after they do general internal medicine. And general internal medicine allows for residents and medical students to understand the full complement of all the subspecialties. And what really attracted me to endocrinology was I really love systems. The fact that that the body has so many different hormones and systems that we commonly don't really understand that's keeping us healthy. And it does take some patience to understand the systems. And the moment you understand the system, you start to understand how you can either interrogate or modify the systems. And diabetes is one of them, but there's thyroid systems, there's neurologic systems, and much of the disease come from our compensation of what we see as problematic, but it's actually a natural response to how your body adapts to either insults or things to really just trying to prevent you from having further sequelae from things that you do or for compensation you do. So that interested me, and through the history of endocrinology, there's been a lot of success in actually treating disease. So that's what interested me. It's not for everyone. Some people really love having things that are really hands-on. They love to see something open. I think those things initially are very gratifying, but once you start kind of understanding the inherent system that nature has provided for us, that was really fascinating. That's what really brought me to endocrinology.
Cool. Well, we're speaking for all people with diabetes right now. We are grateful that you have devoted your energy and time to diabetes patient care. And so, speaking of exactly that, you've played a very big role in shifting LAC and USC's specialty care from a volume-based model to a value-based model. That could not have been easy. Can you tell us about that?
Yeah, so just a bit of context. Los Angeles County is the second largest municipal network, health network in all of the United States. The first one is New York. And so for many of the patients that could not be insured, Los Angeles County houses many of those patients traditionally. And as many people are aware, with the Affordable Care Act, most of those patients now have insurance, at least in California. So I think people throw out the term value-based. And what it really means is we're not getting the outcomes. We're not getting the resources to patients that taxpayers are paying for. That's what it means in a municipal network, right? So everyone, at least in Los Angeles County, the state, we pay into a government system. And for the safety net, what we were seeing is a lot of money actually being squandered and not actually getting and touching the patients. So what value-based means is that per dollar, what are we doing to improve the health outcomes of these patients? And we can do better. So with the inception of the Affordable Care Act, now there's a healthcare system that most private insurers have been doing for many of us for numerous years. But for the safety nets, for the people who are uninsured, if you're going to have insurance, could we manage the money better? And what we've shown, at least since 2010, I was brought in to see if we can actually build an outpatient specialty network to assist with primary care, to see if we can actually manage this money better. And when it's managed, patients have better access to medications, they have better access to primary care, they have better access to the things they need. And that's what it means to create value out of the money invested from the government. And I can speak more to some of these challenges, but Probably
Yeah.
the biggest thing I would say, that's the biggest challenge is, imagine if you're getting healthcare from a DMV, right? That's what government healthcare is, right? So there's DMVs, I'm sure, has had numerous transformations. I myself had to recently get my son to get his first driver's license, and I'm sure it's efficient, but it's nothing like private industry. So how do you change the structure of government so you deliver better healthcare, which in this country should be a right. So this is what I've been working on, and it's a big challenge. It's an ongoing challenge, but we're dramatically better than we were back compared to 2010.
When you talk about this arc of transformation, and I'm sure it's an ongoing thing. You're probably just getting started in many ways. Where have been some of the bigger challenges that you've bitten off and had some success? And maybe it's just like we could just start with like one that you've made some of those changes to make sure that more dollars were being focused on the outcomes of the patients, whether they be diabetes populations or other chronic populations that are doing so much of their management in an outpatient setting.
So the biggest thing I would say, I'll start with probably the biggest management layer, right? You want the incentives tied to the things that matters the most. That is probably the biggest problem, right? So diabetes is not a new disease. Everybody knows that it starts with patient activation. You can flood the patient with information and things, but they live with it day in, day out. We know that prevention matters, diet, lifestyle. We know that access to education, all these things. But, there's only certain things that matter the most for certain cohorts of population. Early on disease, it may be prevention. Later on disease, access to, nephrology and all these things. But the dollars have to be tied to what the patients need. And that type of sophisticated alignment of incentives in the program did not really exist in a complex healthcare system, right? So you can see maybe, in the past where people say diabetes is important, where we gotta prevent diabetes, we gotta save limbs, we gotta do these things. But then the money never trickled down to novel, innovative programs that people are working on, right? And what's really been transformative is getting people on a health plan where you're not seeing patients just once when they hit the emergency room, but actually they're impaneled early, and you see them through the entire life cycle, because they're being incentivized to do this. And then at least right now in the early stages, having performance incentives for health plans and healthcare institutions to receive money when they meet certain outcome metrics. You have to tie the incentives with the program. Then that's the ecosystem that drives innovation. Versus, we don't really care about the outcomes. We're just going to give you a lump sum of money to manage 10,000 patients. That's not where the innovation is going to happen, right? So getting the right incentives into the right healthcare system and the health plan that will actually encourage innovations in a healthcare ecosystem to provide the outcomes before they get paid. I think that's probably one of the biggest things that's transformed a government healthcare system, I would say.
And have there been specific conditions that you've focused on first versus trying to do this across kind of every type of care throughout the system?
So, Matt, you asked these very big questions. So let me see how I can maybe explain this better, at least from the context of a government system that prior to 2010, we did not have a universal electronic health record, right? So if you can imagine, if you went to, let me back up. In Los Angeles County, there's 4 acute care hospitals. There's one at Harbor, Rancho Los Amigos, a rehabilitation facility. There's All of You Medical Centers, and there's LA General. We call this LA General now. So these are 4 acute care hospitals, and then we have hundreds of primary care clinics throughout the entire county. Back in 2010, you could go and be admitted to Harbor, let's just say, across the aisle, and then the patients would leave. We would not have immediate access to those records. We could not communicate, right? So, and then those patients then may be seen in primary care. So there was a lot of waste in just a fundamental foundation of information management. And for chronic disease like diabetes, as you can understand, data is king. You need to have one medical record. You need to have a full, I would say, inventory of all the preventions, right? Eye screenings, nephropathy, all that stuff. And you also need that to be communicating across acute care hospitals to know if the patient's being admitted, getting surgery, things of that sort. That's just the base. And from there, they have to have access to connections like pharmacy, whether it be private pharmacy or hospital-based pharmacy. That structure was extremely fragmented, created a lot of waste. And so we needed, one of the initial things we had to transform was just a base level informatics across the entire county. Okay. And we now have a Cerner-based system, and now Cerner obviously is partnered with Oracle. So you can imagine if you have to house all that data for the entire county, you need an Oracle-based informatics architecture to have all your images, your labs, in one system. Now the patients can come to LA General for their highly sophisticated, complicated diabetes, and I have all their records. That's already a big gain, right? And the patients now have access to their records through the patient portal and know that they can actually get a second opinion anywhere else. That's life-changing for any patient to know that they don't have to go to each healthcare provider and re-explain their entire history, cobble together what they thought was their history, and that created a lot of, I would say, waste in the system. So that was our, I would just say, in our initial transformation, getting everyone on the same healthcare platform. And then from there, build vertical, I would say, vertical products. One of those things are e-referral systems, where electronically, any patient with a health plan assigned to a primary care physician can refer any specialist, and immediately within 2 to 3 days get a response back saying whether or not the patient either can be managed in primary care or receive care in a specialist. So from a system level standpoint, that's not unique to diabetes, is to establish a foundational informatics core and allow specialists to be able to refer and communicate efficiently. Those were the things that impacted, I see, the diabetes the most. And what it did was it flipped the culture of acute episodic care, where most of the patients were generally funneled into specialty clinics because they went to the emergency room or they went to urgent care, and the emergency room doctor would say, "Hey, go to your orthopedist, go to your endocrinologist, or if you don't have one, we'll assign you to one." The culture now is, who is your primary care doctor once they hit an emergency room? We'll address the acute things, but please establish your relationship back with primary care. Primary care now has set, I would say, expected practice, where they themselves can manage base level diabetes from a lot of the endocrinologists. We provided them that level, what we call expected practice information that's updated annually. They then manage the patients, and if needed, they get specialty consultations through the e-referral system. So at this point, it's not just infrastructure. It's now developed kind of a flipped ecosystem where primary is primary, and we have a medical neighborhood as.
Is there even though that's so logical and a great idea, is there a concern that the primary care population is going to be overburdened by more people depending on, are there enough primary cares to handle that flip?
I love that question, Ginger. This is one of the things that people are grappling with, right? So I would say that it's dramatically better than it was before, because there's only a few endocrinologists. I would say 5, 6 in the entire county, right? So there's no way that I can manage 50,000 within my cluster of diabetes. So the fact that we have primary care physicians that's knowledgeable in diabetes and updated annually to be able to deliver high quality diabetes care is already a big gain, right? And what primary care has really understood, and what they do really well, specifically in the safety net, is it has to be team-based. So what team-based means, and I think different, what they call primary care medical homes, PCMH, and this is a very mature model, is that they have to build the teams to be accessible to population-based management for the patients. You do not need to see a physician to refill your medications. I mean, that should be available to get education. That could be done by a community health worker, the medications on refills, right? And within the primary care team, there should be tiers of nurses, care managers, the nurses, and
Okay.
then we now have PharmDs that can actually, they are providers. They prescribe medications. They give them detailed understanding of medications, newer medications like Ozempic or tirzepatide, and this is what it means to have a panel population and a team that's going to manage you throughout the entire continuum. So,
Okay.
so that even with that, there's not enough primary care medical teams to manage diabetes patients. So for chronic disease, and this is where there's I think for the safety net, we're dealing with a lot of social determinants because there's a digital divide. But for the ones that are active patients, there's now a lot of resources, and I've seen it for patients that can actually understand the chronic disease well enough to pull the care into their own domain, right? So they will then nudge the physician when they don't have the screenings. It's already built in their patient portal. They can look at the notes. They can ask their friends, and at least within a health plan, there's ample local resources to help them understand technology enough to kind of build their own care plan. And so I think that's going to be the future. It's where patients are going to be extremely active consumers of what they see as healthcare. And it's not going to be about managing disease. It's really going to be about, their goals, right? So their goals is not to wake up and battle diabetes. What their goal is, look, they want to be healthy, taking care of their family, going to work without having to take too much time off because they have to adjust their medications.
Right.
So
Right.
those are we've always talked about this, with most patients. When we say goal setting, it's our natural innate drive to actually want to live a healthy, productive life, right? We shouldn't have to convince patients. So those things are really going to transform healthcare because the patients will be an active consumer of what they really want from their health plan, which is living healthy and being active. So,
Wow.
Yeah.
Well, I know that
Right.
Matt, thank you for that detail. I know Matt is chomping at the bit to ask you about innovation. Go for it, Matt.
Well, I think Andy set that up perfectly
Yeah.
because a lot of what you're talking about is the future of healthcare, right? And that requires innovation to be coming into health systems. And this is an area that you know quite a bit about, having led innovation efforts many times. And so would love to understand from your perspective, how do you view readiness of some of these technologies to bring into these, especially large health systems? What are some of the things that, you're looking for? And then what are some of the table stakes for bringing some of these technologies into a health system, right? There's a lot of entrepreneurs right now that are tackling big problems in healthcare. What do they need to be thinking about in order for me to bring this to LA County? I need to make sure that I've got these things established, or I need to make sure I have this zipped up. So kind of an open question about, how do we think about bringing innovation into these health systems to start, bringing the future that you talked about to the present or into the present?
yeah. So let me see how I'm going to answer this question. Matt always has the difficult questions here. So let me just at least level set what I see as innovation. Okay. Healthcare is really, honestly, it's not a very innovative field. Okay. And what I mean by this is that we're generally the last to adopt some new technology, right? So we translate technology that's been proven in other industries, and we say, hey, why don't someone has a novel idea, bring it into the healthcare industry. And their challenge is it's actually the challenge that people have in bringing innovation in the healthcare environment is something that's really true and dear to why a lot of us go into healthcare. It's very personal, it's protected, and people who are used to really fast-paced innovation are not used to these type of things, and these are the barriers. And we as a society have to really make a decision about things like privacy, about security, about your personal information. These are the things that prevent interoperabilities and things. So that's one piece that I've seen. And very early on, I've been involved in, on the private side, I've been involved with innovation think tanks to now working within the county, two different beasts. But, it's not new for someone to have a company come in and just say, hey, we can do all these really great things. And then they themselves over a few funding cycles realize, wow, this healthcare is it's not what we thought, right? And it's no fault of their own. It's just that they start to understand all the invisible, I would just say, barriers that is meant to protect our patients, that prevents some of these innovative technology from intersecting with our care. So that's one piece. Second is that healthcare is much of the players are really dominated by a few companies. Okay, and I would say the number one stressor for me as a practitioner, okay, and also as a director, and I said this numerous times. Anytime we want to launch something, is really the big electronic health record organizations. So they're just I think they're getting better, but not at the pace of what we're seeing as innovations across the system. So there's challenges at LA County. We're a big county with major healthcare facilities. A lot of our ask has to be at scale, right? It can't be just in one clinic. It has to, even for us to even get consensus, right? So if I said, look, I want to deliver something, I need to actually get this vetted through our primary care physicians and specialists, and so we have an understanding of what we like, and then we have to then work with the technologists to see if Cerner can build something like this, to contract something and bring something in, and then we have to at the end launch it and make sure it's workable. That entire life cycle it's very burdensome for us, and this is what kind of impedes new innovative technologies from actually being delivered at a healthcare system. And most of the time, what we see is once it's done at scale, things starts to fall apart, right? So technology starts to, I would just say, like medications, they're side effects, right? So you bring something new in and knocks off 10 other technologies in a big connected system.
Yep.
And so I would say, just going back to the second piece, besides privacy and security, our healthcare system technologically has become very complicated, and the folks that own the technology, I don't know if they fully are resourced enough to allow innovations to intersect with their products, right?
Yeah.
So they don't make it easy for when we like something out there, and then when we say let's work with Cerner to see what we can do to build something in, and I'm sure for other companies might be epic. It's very difficult, right? So, and that, I think that stifles innovation. And this is what we found. And I'll just make one a last third point is that, as I said, for healthcare system, we're very legacy driven. Like our med students probably are not learning what it means to be a doctor now in a digital age. That's just because they're taught by many of us that grew up with paper charting, and we're trying to keep up. So what's emergent in new is not really taught in a healthcare industry. So in a system, you have to have, and this is what I really pushed for, was you have to have some safe incubator to show what things could look like, right? Because when you launch something within your own context, the real world evidence is going to be very different than what you studied or what someone's proposed. So any major organization has to allow some level of tinkering, okay? before you fully commit to a full big launch.
Yep.
And we've learned that we've been proposed maybe technology from a Gartner slide, phases of implementation, but some, we never make it to the end, or even when we make it to the end, it's not what it looks like for a safety net organization as big as ours, and our patients are not receiving the care that they deserve. So those are the challenges, Matt. I don't know if those are probably three big buckets that probably deserve your time, but those are what I see.
Each of those has its own question and probably an hour-long discussion. For the sake of time, I guess a follow-up question there. We've talked with a lot of physicians that want to accelerate bringing innovation into their hospitals or into their healthcare systems or even just their clinics. What would be one piece of advice you might give to these aspiring innovators within their hospital or health systems about finding success in bringing innovation in? And I know that the county system is different than some private systems, but we hear consistent things in terms of challenges here. So what would be a great place for someone to start, and as they want to build an innovation program or start bringing innovation in, what's one area that you think they should start really nailing down to increase their chances of success?
So probably the one thing I would say is you have to understand how innovation happens at your organization or hospital. Okay. That seems very abstract, but this is critical. Okay. And I'll give you an example. Most things that you pitch, to be honest, are, if you look at the spectrum of innovation adoption, let me just, if for the people that, Matt and Junior, I'm sure you guys know this, but for the innovation adoption curve, it's a bell curve, right? So there's, on the left, there's the innovators, great ideas, right? And then you once you prototype and you think you've done something, you have to jump that gap to the major adopters, the late adopters, and the laggards. Okay. Yeah. And what in many different organizations, the individuals, and I'm lucky I'm pretty open, but for most, C-suite or executive team, many within the healthcare industry, many of the, I would say, senior leadership are either in the late adopters or laggards. Mm-hmm. Okay. And they will say, I want innovation. But when you pitch it, you're like, wait a minute, you want innovative. And in their mind, they're like, wow, this is a lot of risk. I'm gonna get a lot of people like coming with a pitchfork at me. I don't know if, I can go back to my entire medicine or OBGYN department and say, we're going to radically change this. Right. So then to that innovator, they may feel like it's such a disconnect, right? They're like, yep. On one hand, you want to introduce something new, but then you're, I bring you something that's something new, but then you're having reservations. So you first have to understand from your management team, where are they at? And there's nothing wrong. There's for systems to work at each institution, there's a reason why your leadership is constructed that way. And if a hospital is constructed in a way where they're a research institution, they have people that can see actually and be visionary, and they want new things. So you just got to know who you're pitching at what level and their readiness for this type of innovation in the curve. So if you're in a situation, if you have laggards, okay, at an executive level, you need partners that's in the major adopter category. Okay. So what this means is you have to be able to, if you are on the left, most of the people I see that are very good are in the major adopters. They have a community of folks. That are willing to test. Like if I say, hey, Matt, I got this a great tool that has really great interoperability with Cerner, and it's great, right? They'll test out in the department. They say, yes, this works, right? And then you as an individual, if you're an innovator, you have a major adopter. That's 35% of your, your core folks saying, "Hey, this works. We can vouch for you." And then you take that into to an executive team and saying, "You know what? I'm backing that this is really going to work. Okay, this makes sense," and that's going to convince the laggards, right? So I would say most healthcare institutions want something safe. They want to know it's proven. So you can have a community of folks either in your hospital or actually at another healthcare system, right? So when I really want to propose and move something at LA County, I'll look for another big safety net hospital like Cook County, maybe in New York, where they've done it. They've shown similar technology. It's working, right? So those are going to convince the laggards. But then if you have someone who's very visionary and willing to take risks, a perfect example, Dr. Mitch Katz that was here in LA County. He was not risk adverse. He was actually he wanted to, I would say he's kind of like a Steve Jobs. He could see beyond the horizon, right? So he'd say, "Bring me something." Okay. And he would actually say, "Okay, we will allow you to show us," right? So we could do a proof of concept for 6 months to show that, hey, this is even feasible. This can happen, right? And much of his team that he's grown with Dr. Galley here, Christina Galley, previously Hal Yee, much of these, I would say, innovative Department of Health Service leaders are not risk averse, but they're open to innovation. So they're willing to hear us out, let us test things, and then they're able to adopt it. But each healthcare organization is a bit different. So you have to know the temperature of the leaders in your organization in receiving new technologies. So,
yeah,
I just got a few right now. So,
yep. Okay.
I just want to. I think it's a great conversation. So I'm gonna have to. Yes.
Thank you so much for your time, Dr. Lee. We really appreciate it, and we'll let you get back to work of supporting your patients. Thank you so much.
Thanks, guys. Thanks, Matt. Thanks, Ginger.
Thank you so much.